Dear audience, welcome. Let me introduce you my PhD topic, which is about diabetes mellitus and its effect on oral health. My name is Bulcsú Bencze. I'm a third-year resident at the Department of Prosthodontics and a second-year PhD student in the Translational Medicine program. Our supervisor is Daniel Vég, and our SMS is Bianca Goldzio, and our statisticians are Bencze Szabó and Gergely Agócs. Our vision is to provide adequate dental treatment for the systematically compromised patients, focusing particularly on prevention and prosthetic rehabilitation. In order to achieve this, we would like to find and provide scientific evidence in the possible correlations between diabetes mellitus and oral complications. Currently, we have two ongoing projects. Both of them are systematic reviews and meta-analyses. We have started our first project on the September of 2022 with the title of Investigating the Effects of Different HbA1c Levels on the Severity of Dental Implant Complications. As for the background, there are currently more than 400 million patients suffering from diabetes mellitus worldwide, and this number is projected to increase by an additional 100 million people by the end of this decade. Patients with this disease tend to lose twice the amount of teeth compared to the systematically healthy individuals. This could be either because of chronic hyperglycemia that increases the formation of glycated end products. These products can interact with their receptors, and they release pro-inflammatory cytokines, the likes of interleukin-1 beta and TNF-alpha. All of these can be found in the periodontal tissue. Therefore, diabetes mellitus promotes periodontal inflammation, which could lead to alveolar bone loss and ultimately to the loss of natural teeth or the dental implant. We can measure a patient's last 2 to 3 months of average blood glucose levels with the help of HbA1c. Therefore, our aim is to find an adequate HbA1c level to provide safe dental implantation without long-term complications. In order to answer our clinical question, we have used the PFO format. Our population consists of patients undergoing dental implantation. The prognostic factor is diabetes mellitus. Our main outcome is crestal bone loss, while one of our secondary outcomes is implant survival. We have conducted the systematic search on the 13th of November in 2022 in the 3 main databases with a search key that consists of 2 different domains. After concluding the selection procedure, we were left with 35 eligible observational studies. You can see the results for our main outcome on this slide, which is crestal bone loss. It can be measured on a standard periapical X-ray between 2 different points, the implant abutment junction and the uppermost part of the alveolar crest in contact with the dental implant itself. There is also a baseline crestal bone loss around dental implant, which is considered to be 1 millimeter after the dental implant placement for 1 year and 0.2 millimeters for each subsequent year afterwards. In this analysis, we have used mean differences with 95% confidence intervals, and the outcomes are in millimeters. There are 22 articles in this analysis, and we have used also subgrouping to differentiate between well and poorly controlled patients based on their HbA1c levels, and we have used the ADA guidelines of 8% HbA1c level to differentiate between the 2 groups. The overall outcome is 1 millimeter, which is both statistically significant and clinically relevant as well. However, we cannot generalize this outcome because if you take a look at the subgroup results, patients with well-controlled glycemic level have a comparable crestal bone loss, whereas poorly controlled patients have an even more higher 1.8 millimeter crestal bone loss around the dental implant. We have also investigated the association between these 2 values by doing a meta-regression, and we have found statistically significant association between the values. For each HbA1c % increase, there are around 0.35 millimeter higher crestal bone loss around their dental implants. We have also made the quantitative analysis on implant survival since the last presentation, and we have found that diabetes mellitus itself has no impact on the osseointegration of the dental implant. Therefore, it does not have any impact in the short-term survival of dental implantation. The strength of our analysis is that we could include high number of studies while maintaining strict exclusion criteria to reduce confounding. Our limitations, however, consist that the results for our analysis had remained high heterogeneity despite the subgroup analysis, and unfortunately there were no population match for oral hygiene in either of the studies included. In conclusion, we can say that patients above 8% HbA1c level have significantly worse clinical outcomes compared to patients below 8% HbA1c level. Therefore, we suggest HbA1c level measurements at the time of dental implant planning, and if the patient has higher than 8% HbA1c level, diabetologist consultation should be done. The implication for future research is also contains that the most important thing is to account for oral hygiene, and more prospective studies should be done with the population matching for oral hygiene as well. The manuscript is currently done, and it is submitted in the D1 Journal of Clinical Oral Investigation, and it is currently under revision, and we are awaiting for the report from the reviewers. Our second topic is about investigating the effect of diabetes mellitus on the survival rate of oral squamous cell carcinoma. Head and neck cancers are widely spread malignant diseases in all across Europe, with Hungary being on the #1 spot in terms of incidence rate per 100,000 capita, which translates to roughly 3,000 new cases for every single year. Not only it's widely spread, but it is dangerous as well. It is the 11th most deadly cancer type in this area. In order to reduce the morbidity and mortality of this disease, prevention and early detection is key, and dentists could play a crucial part in it. There is also evidence in the literature that patients with diabetes mellitus have a higher chance in developing malignant diseases. This could be either because hyperinsulinemia, which promotes malignant transformation through insulin-like growth factors, or through chronic hyperglycemia that helps cancer growth by providing ATP. Therefore, we would like to investigate the association between diabetes and OSCC in order to help in the prevention and survival of the disease. We have used a pretty similar format. Our population consists of patients diagnosed with OSCC. The prognostic factor is yet again diabetes mellitus, and our main outcome is disease-specific survival. We have conducted the systematic search on the 10th of July last year in the 3 main databases with a similar search key as well, and we have got around 14,000 hits from the search itself. After concluding the selection procedure, we were left with 140 eligible observational studies. So the next step for this project is to conclude the data extraction process, and hopefully we will have some results for the next presentation. In conclusion, we would like to finish with the second project by September this year and get the first manuscript accepted by the next progress report. I would like to thank your kind attention with a quote from Friedrich Nietzsche: "Truth tends to reveal its highest wisdom in the guise of simplicity." Thank you.
Congratulations for your presentation. I had a question for your first project. So in the first plot, I could see that on both subgroups of prediabetes and poorly controlled diabetes, there was an outlier. So predominantly on the diabetes groups. So do you think that that population could have any confounding factor or any comorbidity that could impact the results?
Thank you for your question. It's very important, yes. Yes, we have many outliers in these analyses. First of all, they have used a very different type of dental implant systems. For example, they have difference in terms of bone level or tissue level implants, and also difference in the restoration. So some studies have used screw-retained dental restorations, which are proved to be more periodontal friendly than cemented restorations. And in this case, they have used cemented restorations, and the follow-up time for that study is more than 5 years. So that could account for the high difference in crestal bone loss between the groups. And also, in this particular study as well, the group with prediabetes and poorly controlled diabetes had a much more significantly higher plaque scores. So there were many confounding factors regarding this study.
Congrats to a very nice study. I would like to ask regarding your first topic, if the population of diabetics is only diabetes first type or second type, if you can do subgroup by the types. And also if there was some info in literature regarding the other outcomes, for example, like HOMA-IR, about insulin resistance, etc. Thanks.
We have only included patients with type 2 diabetes mellitus, so no type 1 diabetes mellitus or any other types, so at least we could shrink the number of population difference in this case. However, there were no other outcomes regarding their diabetic situation except for measuring their HbA1c levels, so we could only do subgroup analysis based on that information.
Thanks.
I just have one small question. So you said those patients with HbA1c more than 8 should have a diabetologist consultation. So what is your opinion? Would you do the implant, or should we wait until their HbA1c is less than 8? So
most definitely wait and push their HbA1c level below 8%. We have chose 8% because basically the whole population with diabetes mellitus can achieve that goal. So it takes account for other comorbidities, shortened life expectancies, and anything like that. So we could ask for each of our patients to have their diabetes status maintained below 8% HbA1c, because it can be achieved regarding their other diseases as well. So I say yes, every single patient whom are waiting for dental implantation should have their HbA1c levels maintained below 8%.
thank you.
So congratulations. Based on the mentioned question before me, I just want to ask if you use this data of your first study in your clinic, if you use it practically right now, deciding about this 8%. Thank you.
Great question. This will be the goal of this analysis, to translate this to the clinical practice as well. As of yet, we do not use it, but we most definitely plan to use this 8% HbA1c level for patients who has a treatment plan for dental implantation. So it's in the future, but we are trying to do it.